Hello, everybody. We're about to start the panel soon. Perfect. So now we'll move on to our second panel of the day, Driving Change with Research, Data, and Advocacy. It will be moderated by Carrie Devlin, a music therapist at Johns Hopkins Center for Music and Medicine. And on our panel, we have Kiona Hayes, a Baltimore-based disability rights activist, Megan Morris, associate professor at NYU, director and founder of the Disability Equity Collaborative, and also on the advisory committee for the DHRC, and Kiana Jackson Swords, chief research officer of data and research at New Disabled South. And I'll hand it off to you, Carrie. Thank you all for being here.
Hi, everyone. Just want to do a quick sound check. Is the audio working all right in the room?
Yes, we can hear you well.
Great. So hi, I am Carrie. My pronouns are she, her, and I'm a white woman in my mid-30s with blonde hair that's like up in a clip. I'm wearing black glasses and a brown short-sleeved cardigan. I'm a music therapist by training and a PhD researcher here at Johns Hopkins, and also a full-time disabled person. So I'm really honored to be moderating this panel today and being a part of what I know is going to be a really rich conversation. So in this panel, we are turning now to how research moves into action. So this panel is really going to focus on the role of data, of advocacy, and of lived experience in shaping real-world change, whether that is in policy, funding, or public awareness, and where these efforts are still falling short. So we're going to open with a lightning round question, during which each presenter is going to respond briefly to the same question. And that question is, how have you used data or research to influence real decisions? And I'm going to go from left to right on my screen. So Kiana H., you are up first.
All right. Thank you. Thanks for having me. One thing I've been looking at over the last 12 years is how comfortable do physical therapy students feel about talking about sexuality with their patients. And, we had them do kind of like a survey, how comfortable they felt. And then I teach a class for them on sexuality and disability. And the students that took my class, they felt totally way more comfortable talking about the subject with their patients than the students that did not take my class.
Yeah, really appreciate that, responding to a concrete gap with education and training. So Megan, you are next.
Hi, Megan Morris, pronouns she and her. I'm a white woman, mid-40s, shoulder length of brown hair, and I'm wearing glasses today, and a blue dress with red on it. I could get lots of examples for this question. I will keep it short. So one of the areas that I focus on is documenting patients' disability status in the electronic health record, or the EHR. So we've done a number of studies with folks with disabilities, trying to understand how they feel about information about their disability being included, what questions, who do they want to be asked by, where do they want it to live in their chart. And then we use this information to actually design a study where we implemented routine collection of patients' disability status as part of new patient registration. And we did this in a health system with 53 primary care clinics, and over 6 weeks, we had 3,000 patients asked about their disability status and information recorded in their chart. And so we were able to get data on, patient complaints, how long this takes, which were really important data points for implementers. So I talk with many health systems and also EHR companies. And when one of the big questions was, they always come at me, is this is extra work for our team, and how can we do this, and how, we're going to offend our patients. And I was able to say, actually, no, we have the data. It takes 18 seconds on average to ask these questions. Think about that. It's not that long compared to, the added benefit you get knowing information about your patients and their disability and accommodation needs. And then, the other point, again, people often say, oh, we're going to offend our patients. And I was able to say, we had over 3,000 patients asked, and we had 0 patient complaints. We did follow-up qualitative interviews with folks. They didn't even remember being asked because it was so not a big deal to them. And so we're able to use that to inform, again, kind of talk to our implementer, the health systems, and many health systems have taken this information and felt then empowered to implement routine collection of disability status at their organization.
Excellent. This is Carrie. Yeah, what a great example about how collecting information can also not only improve implementation processes and practices, but also combat perceptions, about why we might actually be collecting that information in the first place, and how that translates to, maybe perceptions of burden when the actual experience is quite different. So Kiana J. would love to hear your response.
Thank you. Hi, my name is Kiana Jackson Swords. I am a 28-year-old Black woman. I have on a gray Hopkins sweater. My hair is a little bit past shoulder length now. And it's red. I have big square frame glasses and my background is blurred. I think one of the biggest projects that we use in like addressing how we approach real decisions were we partner with Data for Progress here at New Disabled South to run a survey on how Southern voters believe whether disabled people felt inclusive in their local communities versus facing discrimination when it came to interacting with law enforcement. We partner with, like I said, Data for Progress to run surveys across 6 or 7 southern states, Alabama, Georgia, Louisiana, North Carolina, South Carolina, and Tennessee. And what we found in those surveys were that voters overwhelmingly believe that disabled people are included in their or have inclusivity in their community, but that they also feel that disabled people face discrimination when it comes to interacting with law enforcement. And so what we use this surveys and we polled several thousand voters. We broke it down by demographics. We broke it down by not like race, gender, disabled, non-disabled voters, how frequently people voted, all of these things. And one thing we use this report to springboard is the work that we do around community oriented or community centered policing versus law enforcement, our traditional forms of law enforcement, and the preparedness of law enforcement for when they interact with disabled people. And so that is kind of one of the, and we've been able to take this report and use it in conversations, not just in academic or organizing or community center spaces, but also in spaces with legislators and law enforcement as well. And so it's been a really great opportunity for us to bridge these gaps and have these conversations using data that we collected from people, especially in southern states.
This is Carrie. Wow. Yes. A really brilliant example of how, collecting information that is really centered in community preferences and needs can have a direct impact and can actually improve experiences in the community in a way that's really centered in what the community actually wants and needs. And so I want to come back to you, Kiana J. You're in the hot seat for a hot sec, because, I know one of the questions that we talked about was sharing a moment when research or evidence actually shifted policy funding or public awareness. So I'd love if you want to talk a little bit more about that specific example you just shared, or if you have another project or example that you want to highlight.
Um, I think that the tangible way would be the work that we do around home and community-based services. So kind of I always say our specialty here at New Disabled South is like some of the work that we do breaking down the demographics of home and community-based services and their wait lists. We have a lot of information on and I'll kind of define terms in case people don't connect those terms. So home and community-based services are services that exist in the state that allow or support disabled people to live in community and to further the kind of decentering of institutionalization of disabled people. We call them wait lists. Every state calls them different things, but it's basically people apply to get these home and community-based service waivers. And what we've noticed in the South particularly is that people are on these wait lists for years and years and years. We've talked to people who have been on wait lists for like 10, 15, 20 years, people who have passed away on on the wait list just to get services. But also once they get the waiver, have issues retaining the actual services due to a lack of providers. And a lot of that is tied to the extremely low pay that our providers are given in the South. And so some of the reports that we've worked on so far is we've done one in Georgia, we've done one in South Carolina as well. Tangibly, we have saw that the work that we've done in Georgia in partnership with several other disability advocates, so not to take credit for all of that work, but in partnership with several other disability advocates throughout the state, is we produced this report and we gave it to our legislator, and we saw conversations happen. And so for 2 years in a row now, and I think Georgia also again funded more waivers. We were seeing a decrease in the funding of these waivers, but we were able to talk to people in our government, talk to government agencies that are directly over this, talk to state senators, push it out to lobbyists, etc. And we were actually able to see policy change in Georgia, which I say is one of like the biggest highlights of the work that I've done. It's like to actually see them continually and giving more permanent funding. So they can do a thing where they say we'll fund 150 more this year, but we'll keep the baseline here. Well, for 2 years in a row, we saw them agree to permanently fund 150 more every year. So since we released this report, I think Georgia has agreed to fund about 300 more permanent waivers a year. The fight now is still to kind of bump up the pay raises, bump pay raises for our care providers. But that's kind of one of the main, as far as like seeing how data and research and advocacy all work together to push for progressive policy change in southern states as well. And that work is really hard. I'm sure there's a lot of people on here and in the room know.
And if I could touch on that just a little bit, because in my day job, that's something that I help people do. I work for the Center for Independent Living here, the Image Center, and I go around to 18 different nursing facilities helping people sign up for the Medicaid waiver program so they can get out of them and live in the community, and have services. And one thing, that we notice, and especially, this year with the change in administration is, and here we call it the money follows the person program. That a lot of services are like being cut, and even come June, the peer outreach specialists, our positions are being terminated because they only see that as it's billed as admin, and not quite like people don't really understand, like what we do, how integral, we are with helping people kind of sign up for some of those services, because we do things that their support planners don't do. If they're looking for housing, it could be paratransit services, like all of that stuff that they'll need when they get out of the community. And without positions like ours, I'm really afraid for people, because before COVID, SEALs used to get like a list of like, we used to know how many people like transition like within that year. Now they don't even give us a list. So I just know that our numbers here in Maryland just are not looking good.
This is Carrie. Oof. Yeah. And Kiana H, I kind of want to lean into this what you're bringing into the space, which is really talking about barriers, barriers that can actively slow or block change. So I'm curious if anything comes to mind when I ask, what's one barrier or maybe multiple barriers, that are consistently blocking or impacting your ability to enact change, and how have you been working around these barriers?
So some of it I feel like is like people's attitudinal barriers. When I was one of the plaintiffs we sued the city for their inaccessible like sidewalks and curb cuts. And when we started to do like press around like the lawsuit and just let people know kind of like what we were fighting for, I heard a lot. I think it's important, but it's a lot of funding. We don't have the funding for that right now. And what I kind of told people is, you have to look at it in the broader picture, right? It's just not about me trying to get across the street using my wheelchair, because I'm a wheelchair user, but you have to think about the woman with her stroller. My aunt that has had her hip replacement on one side and her knee replacement on the other side. But if she lifts her leg up too high, she can get disoriented. And then you don't want her falling, in the street. So we kind of gotta have to meet people like where they are and just educate them that accessibility for all means like all of us will have access to anything and any possibility, like that we need. You don't have to necessarily use a wheelchair for something to impinge on you being able to safely walk down the street, because I believe it's only about maybe 10 to 15% of the sidewalks and curb cuts that are fully accessible in the city. And I mean, that number is just that's outrageous. We can do a lot better. And we did get a commitment from the city that they were going to invest in 311 and kind of tracking some of the problems. And that's all I really wanted, like in the beginning. My husband says I'm a treat date sometimes because I'm easy to please, but I'm also a realist. So I'm just like, look, I can go for let's do a long-term commitment, but let's just start putting these things in place so I can go to work safely and I don't have to ride in the street.
This is Carrie. Thank you. Yeah, I really appreciate how in that response you are holding space for your own lived experiences, for the lived experiences of the broader community. And that includes disabled folks, but also includes most people who live, all people who live and work in this community, that access is for everyone, not just for a small group of people. So thank you for that response. And I want to invite Megan, in your work as a researcher, to kind of respond in parallel. I'm curious what some of the challenges are that you've experienced in translating research into action or practice.
Yeah, this is Megan. I would say it starts at the very beginning of research, of sometimes the research questions that funders want to fund are not necessarily reflective of what might necessarily be the needs of the population or the priorities. Similarly, research takes a really long time, from trying to get funded, and that can take years. You get funded, and then you have a 3 to 5 year project, and so it could be a really long time before you produce the evidence that people need right now. And so that is one of our barriers. I would say another barrier is with funding is that we can get funding to do the project. And as Anjali mentioned this morning, is we are getting better at participatory action research, and including people with disabilities as our collaborators, our co-investigators, are leading our projects, which is great. But then we do the project, and then you publish in an academic journal, and there's not necessarily the funding or that next step of how do we then translate it into action. And again, traditional funders like our federal funders, NIH and others, is better about this, is how do we then kind of fund the work to translate it into the community to folks who can kind of take that evidence and run with it and make change.
Yeah, it is kind of funny. I also work as a researcher and have engaged in quite a lot of participatory research projects and have encountered some of these same barriers where, the institutional review boards are perhaps not situated to fully engage disabled community members as a part of the research team if they are, not affiliated with a larger institution. There may or may not be accessible human subjects research trainings for community members who want to engage, who don't have an academic research background. And so I'm just sitting with you in these challenges that funders also may have to look to broaden the scope of what they consider valuable dissemination efforts, that maybe the highest impact place to share information is actually not in an academic journal. And that really shifts how we as researchers think about what it means to successfully complete a project and close the loop back with stakeholder communities. And so this kind of brings me, I feel like this ties in really nicely to an open question that I'd love to invite all the panelists to respond to. Where do you see opportunities for stronger collaboration between researchers and advocates, especially at institutions like Johns Hopkins University? And I'll just kind of open the floor for response.
I'll go. I think one is like offering forums like this to we're a nonprofit organization, so we don't have access to the kind of base of influence that a institution like Johns Hopkins has in terms of base. I mean, people that engage with the work that we do, the alumni base, right? The access to these brilliant researchers and people that work in these fields, but also in these sort of more federal, academic geared spaces. So I think having actual research partnerships. We've had a few partnerships with more kind of with schools to just help do recruitment for their research, to help them build focus groups, to help them target the work that they're doing. I think one really great partnership we had, and I think I may have saw one or two of them in the chat, but we did a big research project with National Disability Institute, talking about the intersection of technology and disability rights and worker rights, right? This really niche thing, but I think that collaboration was very beautiful in that it allowed us to have their audience will also translate that information in a way that targeted our audience as well. So I think it's working with not just including disabled people in research, but also prioritizing disabled researchers, and having disabled researchers be your principal investigators, right? Like seek funders that want disabled people to actually do the research and not just be the ones that are looked at, because there are so many disabled researchers. We know 1 in 4 adults in America are disabled, and we know that we are represented in research, but whether we disclose that or not is also like a stigma as well. So I think it's like making sure that disabled people feel welcomed in the field, and not just like being the ones that are constantly being asked questions, but are the ones helping us formulate the questions. And I think that, like I say, institutions like Johns Hopkins even launching like a disability health research center, right? Like shout out to y'all. I want to say that like this is amazing. But like even launching a center like this highlights the importance of disabled researchers and the importance of continuing to fund and continuing to investigate disability, but not just like diagnostic or prescriptive, but like the actual lived experiences of disabled people. And how do we turn that into changing that reality, bettering that reality, and reducing stigma of disability in like our society.
Mhm. And I would say this is Kiana H again. That Kiana said it right. Having forums like this, and also I just stay connected to, like different organizations that I worked with in the past. And, I'm on a ton of different community advisory boards that I just really try to, I'm very community I'm very community, I, I'm very community minded. So I just always, just feel like having people with that lived experience, with those disabilities at the table is just very important. Staying connected. Like I said, with I used to work for the Baltimore City Health Department. I still do a lot with them. So just really trying to invite everyone at the table. Like everybody has a place, a part to play, and in us pushing for a completely accessible society. And the more voices and the more we can encourage people to like have that seat at the table, I think the better society we can build together.
Great. Building off of this is Megan. I would say, again, what both Kianas have said is how do we just come together and find spaces to communicate? I would say I would take it, maybe one step further, is to really understand what each other's goals and needs are. Again, researchers need to have this kind of open ears to say, okay, what are the challenges? What are the priorities of your community? How would you like to engage in research? What would that look like to you? But also, practicalities of like, what do does it make sense to partner with your organization? How do we set up a collaboration of having you bring you on as co-investigators? What are your needs? I think given today's climate, is there's just fewer dollars in both research, but also the nonprofit space. And so how do we come together and support each other and during these times, and find opportunities to sort of kind of pool resources, I guess. And then, on the other side from researchers, we also have these priorities and pressures of chasing funding and asking fundable questions so that we can, one, keep our jobs and keep our staff and keep the work going. And like I said before, sometimes it takes years to get a project funded. So really patience for the community that that this takes a long time, and it's and we hope you stick around and continue to partner with us through this process.
Thank you. This is Carrie. I wonder if now we might sort of open the floor for questions. I don't know if there's any questions from folks on Zoom. You're welcome to submit them through the Q&A function or in the chat, or if there are some questions in room that people not in the Zoomosphere can help us with.
Quiet.
Yes, we can hear you.
Yeah?
Yes.
Okay, great. Okay, thank you. All right, questions in the room? Questions online? Yeah. Sorry, I'll try and...
Thank you all for this panel. It's been really interesting to hear your perspectives. My name is Becky Seltzer. I'm a pediatrician and researcher here at Johns Hopkins. And one of the things, you know, Megan, I guess you're the one situated and Carrie within the academic space, but you talked about is like meaningful dissemination. And this is something I've struggled with too. If you do the research, you want to make the change, how do you translate that into meaningful advocacy and policy in a place where academia does not give currency to that, both in our promotion or financially supporting it, and you're ending up doing this, at least I feel like here at Hopkins, on our quote, you know, free time, on all our free time that we have. So I'm curious, or anyone's here in the room too, like thoughts about that and how do we move the needle or create better partnerships with community organizations so that they can take some of our research and maybe do some of the advocacy using their own voices. But this has been an area I've been trying to work on and curious what you all think.
This is Megan. Great question. Yeah, I was going to say, if you find out the answer, let me know. I would say that I guess a few things. There are, you know, a few places like some of the Pcori engagement awards do allow some dissemination. I don't know if anyone's on the call from foundations. I feel like this is a space also foundations could step up into. And I think that's one challenge we have in disability is there's not one clear disability, you know, health foundation. And so we're kind of trying to find partners in different places because I think in other spaces they have historically funded some of more dissemination and translation work. And so how do we find those partners in the disability health space? I do think that the more, and I think, you know, some of us have been talking about this, how do we better inform each other of the work, you know, how do researchers better inform, again, disability nonprofits or disability policy folks. And so I think we need to come together and have some conversations of how do we set up that infrastructure. And it might be informal and volunteer infrastructure, but like to let each other know of what is going on. I think, again, the disability community is so diverse, which is great, but it also means sometimes we're more fragmented. And so how do we kind of, again, build those bridges and build those ways for dissemination? Yes, I would love for us to see some more from, you know, again, hearkening back to what Anjali said about the new NIH priorities moving forward. I would love to see NIH put out some announcements related to how do we study evidence-based dissemination and that translation. I don't know if that might be pie in the sky, not feasible, but that would be ideal.
Hi, so I am a student with disabilities at the Bloomberg School of Public Health as an MPH student. I would love to hear from you. I've been hearing your great advice to researchers and institutions on how to bring researchers with disabilities to the table, but I would love to hear the other side is what is the best step you have taken to make connections and find opportunities to do disability related research as a aspiring researcher with disability.
Um, I think here at New Disabled South, our entire team, our researchers, um, our entire research team are disabled researchers. My apology for and we all come from very academic backgrounds. We were all kind of, I always say my goal is to snatch researchers from the grips of academia. Um, but we have to fund an infrastructure to be able to do that. But so all of our researchers come from a very academic background. Matriculated through Johns Hopkins myself. So shout out to the home base. But I think it is making those opportunities visible and like intangible. I think we hear it in like theory a lot, but like in practice, and I'm sorry if I'm saying like a lot, I am Gen Z. It is a filler word. Um, but so it's making those relationships tangible and seeking and actively seeking out those opportunities. For example, I was reached out to by someone from Georgia State to write an article in Stat News, right? That's like, oh my gosh, that opportunity is not offered to a lot of like nonprofit spaces or to like a lot of nonprofit researchers, because I think there's an idea of like what nonprofit research looks like, and that is not very academic, or like it doesn't target academia, especially when you're looking at sort of community-based research institutions. It's this idea that, oh, we're doing pamphlets or doing like quick statistics. But I think there are so many and coming from like the lens through the work that I'm doing, there are so many blossoming opportunities from people in academia that are wanting and actively seeking out these partnerships with groups that have researchers that are more community based, that come from academic frameworks as well. And I think that the more researchers that we have that are kind of have academic backgrounds and are coming into nonprofit community-based spaces, that are getting that language, figuring out how the community talks, figuring out how the language changes, then taking that back to academia, it is making those partnerships more feasible, because we want our research to reach people. We don't want them just kind of living in the archives of academic journals. We want like all of this brilliant research and all of these brilliant ideas and all of this money, honestly, that is being pumped into research to have tangible outcomes. And where I'm seeing a lot of tangible outcomes come from are from researchers that are working in these spaces. So I think it's about bringing them to the table, but also making those partnerships more public, more highlighted. I think a lot of us in research want to highlight our kind of big federal partnerships, but I think we also have to highlight our big local community-based smaller nonprofit, maybe not as known, highlight those as well, to make that relationship just as tangible and just as public, so that people see that we are actually in community and doing the work and building that trust between not just community that is impacted by our research, but researchers that are also impacted by community as well.
This is Megan. I would say for kind of junior folks getting into this space is one, there's not a whole lot of us. So the field is very open. So I think sometimes that can be almost intimidating or one side, or like a kid in a candy shop. There's just so many different areas to focus on. And so sometimes it is hard to narrow down and figure out what is the area or the question that you want to address. So I think that's kind of the first, figuring out, at the end of the day, what do you want to be spending your time doing? Because, for example, there's a lot of rejection in research. There's a lot of failed grant applications. And so what do you feel so strongly about that you're going to, even if you get rejection after rejection, that you're still willing to like keep moving forward because you're passionate about this question. And then I would also ask that those who were more senior in the again, disability health research area, is that, again, there's not very many of us, so please be patient with us. We're, still, it's just been a few years since disability has been declared a NIH disparity population. So we're still figuring it out ourselves. And so recognizing and giving kind of all of us patience as we're trying to really kind of carve out and really define this disability health research field.
This is Carrie. Thank you for those responses and that question. I'm just noting we have about 4 minutes left, and I'm wondering if we want to do like one more little lightning round moment with the panelists, because I'm kind of curious, what is one thing for each of you that you hope people are going to leave this conversation thinking about?
Well, this is Kiana H. I hope we can leave this conversation, like one, feeling more empowered, two, that, if we're collectively using our voice, we are stronger together than we are apart. And, even though, our focus, might be one thing, might vary in some ways. We're all just trying to make the community better as a whole. And I think whenever you get people and we all have that goal in mind, that makes us stronger. We're always, that always makes us stronger.
This is Kiana J. I'll say that the thing I would like for people to leave here with is the idea that everyone is wanted in both of these spaces. The community wants researchers who are advocates and wants researchers that are in community, and research wants community in our research as well, because I think they are needed. It is a very symbiotic relationship. They can't live without each other. I think that transparently, researchers have a lot of it's very hard being a researcher. It's also very hard being a community that constantly needs research done, because it seems like there's never any answers coming because of how lengthy research takes. And so I think that understanding that both of these communities need and want each other, and that if we work harder and not harder, I think everyone works hard, but like continue to work hard to build these gaps, then we can fill in the time, we can fill in for when the research is funded to when it is completed with the partnerships that we have, by pushing our updates to these advocacy organization, pushing our like interment findings to these organizations, keeping people excited about the work that we're doing, because research is exciting. I don't care what anyone says. And getting the community excited and invested in the work that we're doing as well. I think understanding the importance of that relationship is what I would really hope people leave this conversation with.
This is Megan. Let's say both. What has been said has been perfect, so I'll try to add something. But even just building off of, again, kind of the morning conversations is, we all know right now is a tough time. And I have the hope that it is a blip, and that we will get through this and we'll get through it together, and we'll come out the other end, and we will just see this blossoming of this is our heyday of disability health research. There has been so much progress that has been made over, especially over the last few years, which is so exciting. But for us to really, again, make sure that we, what's the core of what we're doing? How do we improve the lives and health of people with disabilities? And if we just kind of keep that front and center, again, whether we're coming from an advocacy or research, how do we come together and really just see that as our priority, and find opportunities for us to collaborate, share spaces, and support each other in doing this work.
This is Carrie. Thank you, everyone. I'm just acknowledging that we've come to the end of our time together, but really appreciate the richness of this conversation. And I'm leaving feeling the community connections and the power that comes from that. So thank you all.
Yeah, this is Bonnie. Thank you. That was a fantastic conversation. Really appreciate each and every one of you for all the work you're doing. Thank you so much. All right. Next up, we have the pleasure of inviting Dr. Rebecca Seltzer to the podium. Dr. Seltzer is a pediatrician here at Johns Hopkins, and we are going to view her documentary and then have some time for conversation. So give us just a few seconds to switch over to load the film, and I'll turn it over to Rebecca while we do that.
Hi, so nice to be in this room with all of you. I can just provide a little bit of context before we start this film. So I started doing research focused on children with disabilities and home accessibility around 6 or 7 years ago, in response to much of my research actually focuses on the overrepresentation of children with disabilities in the child welfare system, and was finding that a decent number of kids were entering because of housing issues, which seemed morally very problematic, not better supporting families to be able to stay together. And so this led to a bunch of research asking just families what their experience was with housing, which led to a lot of discussion about not just stability, but really accessibility, and now has launched into a bunch of different research projects. So we had all of this data and stories and photos and images of families that they shared with us just about how challenging it is to live in a home when it's not designed to meet the needs of their child or their family, and then how really small changes to the home, even better, really big changes to the home to promote accessibility can really promote safety, quality of life, function, not just for the child, but for the entire family. But people don't know about this, and I don't think when they think about home accessibility, they think about kids. I think, honestly, I'm in a lot of rooms where people forget that children also have disabilities. They think about aging in place and accessibility for older adults, and I'm kind of the one who's always like, okay, well, don't forget the kids. So in the discussion before, we talked about how do you translate research into advocacy and policy, and so tried to think about how do we take some of these themes we've come across and share these stories more broadly for education and for advocacy. So I partnered with colleagues here at the Berman Institute of Bioethics. They had the Ideas Lab. It's led by Dr. Lauren Aurora Hutchinson and her team, in addition with consultation from Dr. Sweener and with parents who have lived experience of having children with disabilities. We reached out to families across the country and ended up narrowing down to 3 families, which you'll see in this film, who used their own cell phone cameras to really just document what life at home was like for them, with the hope that we could elevate this in the consciousness of the public who's set to see this film. The film's publicly available, www.feelslikehomefilm.org. Feel free to share it if you ever want to put on a screening. Happy to partner on that. And then it's also launched another initiative that we're putting together here with my colleague at the School of Nursing, Dr. Andre Nogueira, who's back there, called Opening Doors to Home Accessibility. We had a policy convening here a year ago in this exact same room where we showed an early screening of this film. It wasn't done yet. And we're really trying to launch that initiative to improve, again, thinking about advocating and policy change around home accessibility for children. And you can learn more about that at openingdoors.design. So, get started. I'm happy to take any questions if people have for lunch.
Sorry, I don't have a... Test. All right. When you were making this film, who was your desired audience or audiences?
Yeah, great question. A lot of different people is the hope. And this just launched, it hasn't been that many months, like the end of last year, we launched this. So originally we were thinking about, my main came to two different audiences and now it's expanded since then. One is to educate providers who are taking care of these kids. So I'm a pediatrician. I got no education about what life at home is like for the children I take care of. I work right across the street. We take care of a lot of children with complex medical needs, different types of disabilities. And I see them in clinic for 15 minutes, or when I was in training, I would see them at their worst in the hospital, and I never got to see them at home. I'd prescribe equipment. I think I was like doing a great job because I was thinking about accessibility and like, let's get you a Hoyer lift, let's get you this. And parents would say, no, we're good. And I'm like, why are they saying no? And then I realized, do you know how big some of this equipment is? So for some families, it's not practical to have it. For others, they've been trying for years to get it, and insurance keeps denying it, and they don't have money to pay out of pocket. I never thought to think about home modifications. I never thought to think about what are the resources in our community, like assistive technology programs, like Medicaid waiver programs, that I should be telling all of them as soon as possible to get on waiting lists for these things. So one is to educate by letting people just get a glimpse into what life at home is like, both to see, I think, the beauty of families and family time, and that these children have great days, and it's not just like when we're seeing them acutely ill in the hospital. So that was one piece of it. I think it can be used to educate not just medical providers, but all different types of ancillary healthcare team members, PTs, OTs, speech therapists, anybody who's working with these children, educating architects, contractors who we know from talking to families, even when you can get resources to do home modifications, it's really hard to find a contractor that knows anything about accessibility, and it's even harder to find one who knows about working with children with disabilities where their needs evolve over time. And so you have to think about what's a modification that's not just going to work today, but as the child grows, as the parents age, what's going to work 5 years from now, 10 years from now. So educating in that regard, and then wanting to get it in front of policymakers to, again, recognize that children and families have these needs, trying to put more resources in place, hearing how families are talking about, yes, there are waivers, but you have to wait a year for them and you can't apply for it until you need it. I think that was that quote I've heard so many people talk about. And so to elevate that, and also just like the public consciousness, let people know that like these are great kids in great families, and that accessibility really matters for all people, but that we should be thinking about that. So we're really happy to just get this in front of anybody who's willing to look at it and engage in conversation about it. And I think it does do better when it's paired with some conversation and context instead of just watching it. Yeah.
Oh, we're good now. All right, thank you really for sharing this. It's incredibly compelling. And I guess I wanted to ask if you could share a little bit more about how you invited people to be part of the film, whether they were patients or folks that you talked to from the community, or how that outreach really worked. Because as we increasingly think about trying to translate research results and clinical impacts to communities where they impacted, right? Inviting those persons to be part of this work is something that we're always thinking of, and being really conscious about what your process was and how you went about doing that would be awesome to hear.
Sure. So I intentionally did not want to have any of my patients be in this. That felt wrong. So we reached out to different networks we had of like parent partners. I work very closely with people with lived experience on all the research projects I do. I think it's obviously critically important, as do all of us in this room. And so I had networks in place from the last several years of partners that I've worked with on research, who then reached out to networks. So parent advocacy organizations, self-advocacy groups. Within listservs I have of medical providers who do take care of children with disabilities and complex needs. And we just cast a broad stroke to different listservs, put together a really simple interest form to say, reach out to the producers if you're interested in being part of this work. And they got a lot of responses from families across the country. They ended up narrowing down to interview around, I think it was like 20 families where they did interviews with. And then from those 20 families, there was thought that went into getting some diversity of age, experience, backgrounds, location where people lived. One of the things that we were hoping to get in the film that we didn't get much of is children who could also speak for themselves. So Mia is somewhat verbal. The other two children were nonverbal, and we hope that their personality still came through with, the footage. But the film ended up being a lot more from the perspective of the caregivers' voices. So the second part of this project, and this was all funded through Johns Hopkins through a Discovery Award, is making an audio documentary, which is in the process right now. And so the audio documentary is taking some more of those stories from those other interviews, but it's also working with a colleague who's at Kennedy Krieger. His name's Chris Mason Hale, who himself is a person with disabilities and does a lot of disability advocacy. And he's also is interested in the film, like the learning about the audio documentary. So he's actually working with Lauren, who's the director of the Ideas Lab, in partnership. And we are reaching out to siblings, so kids with disabilities and their siblings, and doing audio documentary, getting conversations amongst the siblings, and then his experience of being a child and growing up with disabilities. So we're trying to get more of that perspective through that. But there was a lot of thought that went into what's the right way we even capture these stories. Like originally we were going to send a film crew, like a professional film crew, into the homes. And then we had some concern about like consent and like what did they actually want to be shown. And we felt like if we just have them film it, then there's a lot more control over what they're sharing with us, as opposed to us going in also on a random day. Is that the day that the family wants to be captured? So we gave them time, and then they worked with the film team to kind of piece together the story. But yeah.
Thank you.
Mm-hmm.
I'm curious if any parents or families have raised concerns about cost of housing. So for example, nowadays it's really challenging to afford to purchase a home, it would be more ideal to purchase a home, because then adding the accessibility to the home is permanent and they can stay put. But because that's out of reach for so many families, they have to go to rental house. There have been concerns about working with landlords to make modifications, and I imagine there might be tensions with landlords who might deny those. And then there's also, I'm curious to know, there's concerns where many families may move from rental to rental every few years because the cost of rental goes up, especially in cities or states that have no rent control cost, where they can just choose however much they want to increase the cost of rent annually. Mm-hmm. So that means they move from one place to another, then they have to rebuild all those accessibility and do the modifications. I'm curious if those concerns have been raised and how are those addressed?
Yes and yeah. You brought up a lot of important points. So one of our first studies we did was looking at household and household expenses. And one of the things that came up a lot was, so families who have kids with complex medical needs and disabilities, there's a lot of research out there that they face significant financial strain. There's a lot of out-of-pocket costs. Often one parent has to quit working to stay home and help take care of the child. So at baseline, they're having challenges. So then being able to afford a house, to have stable housing, is a challenge, because housing stock, as we know, is really hard. They're also often making trade-offs of, I want a house that's close enough to the hospital, but often where tertiary, quaternary pediatric specialty care centers are in cities or urban hubs that are more expensive. So maybe they could get more space and have a more accessible, larger home that can accommodate their equipment and is a single level if they went out to maybe a more rural area. But then when they're out there, they don't have access to home nursing or other resources or benefits through school programs, or it takes them 2 hours, like our families on the Eastern Shore, to come here to Hopkins to get their medical care. So families talk a lot about how they're constantly making trade-offs for finances, size of home, location of home, renting versus owning. And then the renting versus owning is a huge barrier families talk about with modifications. A lot of the programs in their regulations restrict doing certain permanent modifications for renters. There are now programs that will let renters tap into some of the resources, but it just can't be permanent changes. So they could get a portable ramp, or they maybe could get some assistive technology in the home that they could take with them. The landlord still, like you said, has to agree to it. So I think there's major equity issues in how they're accessing modifications based on that renter status. Or families, if you have some of these waiver programs, right? Like, let's say, I think in Maryland, it's like one of them is $15,000 every 3 years. So do you really want to spend your whole amount of that money knowing you might move and not be able to tap into funds again for 3 years because you're kind of locked out of that funding for a period of time? So people just might not utilize it at all. So it's a big challenge. I don't have the solution. I'm happy to talk more at lunch.
All right, thank you so much, Dr. Seltzer. It's an amazing documentary. I can't watch it without crying, even though I've seen it many times. We are now going to take a lunch break until 1 o'clock, and we'll return with our afternoon programming. For those of you in the room, we have lunch just outside those doors. Apologies for those online. We do not have lunch for you, but are grateful that you're joining us and hope you'll join back at 1 o'clock. Thanks, everyone. Okay, thanks everyone for the patience. This is Bonnie. Of course, all the technical things go wrong, even though you try them out beforehand. So appreciate your patience. All right, so I am really excited to get back to the conversation, and our next panel is on making research disability inclusive. Our panelists include Jean Hall, Professor Emerita and former Director of the Institute for Health and Disability Policy Studies at University of Kansas, Scott Landis, Professor of Sociology at Syracuse University and co-founder of the Disability Health Equity Research Network. Grace Joe is here in person. Grace is a research assistant at the Johns Hopkins Disability Health Research Center. And our amazing moderator is Dr. Jennifer Deal, who is the director of the Center for Hearing and Public Health here at Johns Hopkins. Take it away.
Thank you so much, Bonnie. Really appreciate it. So this is Jennifer. I'm a middle-aged white woman. I'm wearing a gray t-shirt and a black jacket. I use she, her pronouns, and I am autistic, and I do identify as disabled. And so this afternoon, we're going to shift our focus a little bit. So we've been talking a lot this morning about impact, and now we want to talk a little bit about process and look a little bit more closely at what it means to make research disability inclusive in practice. We've talked about collaboration and impact, but inclusion is what shapes how research is designed, conducted, and shared from the start. So the goal of this panel is to explore how we move from including people with disabilities to truly partnering with and learning from them throughout the research process. We're going to start this panel in the same way that the panels this morning began. So we have a question for all of our panelists. And if all of our panelists could, please just introduce themselves when they, answer this first question. Jean, if it's okay, I think we can start with you. And the question is, what does disability inclusive research actually mean in practice and not just in theory?
Okay, hi, my name is Jean Hall. I'm an older white woman with short brown hair. I'm wearing glasses and a yellow button-up shirt. My background is kind of a blurred beige, and my pronouns are she, her. To answer that question, I guess I would say disability inclusive research means that people with disabilities are equal participants in all stages of research, from conception to dissemination, not just as research subjects, which has historically been the case. For research work that requires academic achievement, some examples of what inclusion means in practice include providing appropriate accommodations to college students with disabilities and addressing barriers to graduate education and university positions for people with disabilities, such as ableist requirements for full-time work and in-person teaching. Also, it might mean that universities need to step back and really evaluate the educational requirements for many of their positions. In my experience, there's some degree of academic snobbishness to address. For example, I knew a person who was like a coding genius, but he only had a community college degree, so he was automatically excluded from many positions at my university. He would have been a great asset to a disability research team, but he moved on to a better paying job in the private sector. At the same time, that means that research teams must avoid tokenism and only hiring someone to check a disability box. That's not inclusiveness. So it's awareness of these issues and addressing them in a meaningful way.
Thank you so much, Jean. Grace, can we move to you next, please?
Yes, so my name is Grace. I'm an Asian female, she, her pronouns. Jean Hall, Dr. Hall did an amazing job answering the question. I'm not sure if I can add a lot more, but just to highlight the need to include people with disabilities in all stages of the research. So not just, finding a problem during data collection or data implementation and then scrambling to find a solutions or accommodations, but actually from the design till dissemination process, thinking about people with disabilities and including them in your research, design, and study.
Thank you, Grace. Scott.
Yes, my name is Scott Landis. My pronouns are he, him. I'm a white male who's low vision and immunocompromised in my mid-50s. I've got brown, unruly hair and a graying beard, blue glasses with an opaque right lens. I'll keep it short. In practice, I think the fact that we are discussing disability inclusive research, while necessary, means that we have set the bar too low. My sentiments are what we really should be aiming for is disability-led or disability co-produced research.
Thank you so much. I really appreciate all the perspectives on this question. And I do confess, Scott, I ended with you because I figured we would be having some of this conversation. So I do appreciate that. And I also really appreciate, Jean, your focusing on really highlighting that there are systemic barriers to this that really need to be addressed in our training and in our hiring processes too. I think that's so critical. Thank you. Jean, this next question is for you. So where in the research process are disabled people most often missing? So do you feel like it's in the design, the recruitment, dissemination, other areas?
Hi, this is Jean. I guess if I had to choose, I would say the design stage, but I don't think that's completely accurate or it doesn't reflect the bigger picture. Much of academic research is conducted in response to calls from local, state, and federal governments, and also from private foundations and funders. And many of these funding agencies or entities issue these broad funding priorities that don't address the needs of people with disabilities because they don't include people with disabilities in developing those priorities. So I think funding agencies are often not asking the right questions, which makes it difficult for good disability research to happen. In my state, there was an entity that had the perception that Medicaid enrollees with disabilities are carelessly missing appointments and not taking personal responsibility for their health. And their research question was, how can we change their behavior? So fortunately, my research team had a good relationship with this entity, and we were able to convince them that that maybe wasn't the right question, and maybe the question was, why are Medicaid enrollees with disabilities missing appointments and apparently not taking responsibility for their health? So I think a step back from the question you asked me, it's important to advocate for inclusion of people with disabilities among these state and federal agencies and foundation staff and the work that they do, and understanding that disability is an element of human diversity, and they need to include it as a first step in disability inclusive research. So that's one problem. Sometimes the wrong questions are being asked. But getting back to your question, people with disabilities also have multiple barriers to being part of a university or private research team, as I talked about in the first question. So they're often not included in proposal development and study design processes. It's often only after a study is fielded that people with disabilities are invited to be involved, usually as participants or as advisors, and that's really too late. Another example, at my university, there was a person who developed a really good exercise intervention for people with mobility disabilities, wrote a proposal, got funded. In designing the study, she made sure that the building where the intervention was going to be offered was accessible, but didn't take into account that many of the routes to get to that building were not accessible, and the site was not on a public transportation route. In addition, they were going to do a bone scan or a DEXA scan pre and post intervention to check on whether bone density improved. And even though the researcher leading the study had called the facility and asked if their DEXA machine was accessible, and she was told it was, when they actually started sending research participants there, they found it wasn't accessible. That, yeah, if you could stand up out of your wheelchair, then you could get onto the DEXA table, but if you couldn't transfer because the table was too high, then it wasn't accessible. So anyway, the study was a good study. It had a good intervention, but just the details of it were not planned correctly because a person with a disability hadn't been involved from the beginning, from the proposal writing to the site selection to checking out all of the equipment. And then the study gets a little bit diminished because they had to take the DEXA measurement out because people couldn't do it. And that's when people with disabilities need to be included in all of those steps. And I think that funding agencies are beginning to understand that and require meaningful participation of people with disabilities and people with lived experience at all stages of research. And we, as disabled researchers, really need to be pushing for that. And I think that efforts like you're conducting today, increasing awareness about making research truly inclusive and, as Scott would say, co-directed and directed, is really important. So I appreciate the opportunity to be here and share insights if I can and answer questions. And incidentally, if you want an answer to why Medicaid enrollees miss appointments and apparently don't take responsibility for their health, I would be happy to talk to you anytime.
Thank you so much, Jean. That's incredible. And I do really appreciate your perspective on thinking about inclusion up front. And I might just add, I know, many of us in the room are students, and as students, we don't always get the chance to go out and collect our own data. Sometimes we're working with data that's already been collected. And I guess I would just put a plug in that in the same way, involving a biostatistician or others on your team, when you're thinking about that data, even if it's already collected, how important it is for inclusion at that stage too. So I really appreciate those thoughts. Thank you. Scott, this next question is for you. So how do you move from including disabled people as participants to engaging them as partners or leaders?
Yeah, this is Scott. And I'm kind of repeating what I said. Well, I think discussing disability inclusive research sets the bar too low. In my opinion, it should be abandoned altogether. I think we're probably too far along to do so at this point. And so if we try to think about how do we move forward in such a way that allows disabled people to not only be participants, but to be leaders of research, I think we have to push for, like I was saying, disability-led or disability co-produced research. And in order to do so, in my mind, we need a clear typology of disability inclusive research because it means so many different things at this point in time. The way that I think about it is this could be used for maybe even self-reporting by researchers, that when you do a research study that you would self-classify the type of disability inclusive research that you're conducting, because there are very different types. Jean was highlighting some of those, especially on the bad end of things. I mean, based on the research that I read, I mean, I think of maybe 4 or 5 categories that I think if we started using things like these to describe our research, it would help clarify not only the state of where the field is, but allow some potentiality to move forward by being able to adjudicate which types of inclusive research are working better or not. So, I mean, here's the ones that I think about based on research that I read. I mean, and I'm starting at the low end of what I don't think we want. I mean, to me, this lowest rung, if we did kind of a topology, would be disability exclusive research. And this is kind of what we all are against. I think we can all unite in that. And this is research, and Jean's illustration, I think, highlights this. It's research on disabled people that does not in any way whatsoever give thought or consideration to the perspectives of disabled people. I mean, I think it's easily recognized as unhelpful. And it's what I think, like I said, we all agree we're trying to move away from. So to me, that'd be kind of low rung if we had a typology. The next one to me is interesting, and it's what I would call exclusionary disability inclusive research. Or, I mean, you could call it disability inclusive research in thought only. I recently read a paper that really illustrated this in my mind. They were focused on making disability research on people with intellectual and developmental disabilities more inclusive. And I was excited about the paper, but funny thing, funny not haha, funny thing was that as I read the methods, it was obvious that they had not in any way whatsoever engaged people with intellectual disability in the process of trying to decide what are the best practices for including people with intellectual disability in research. And so they were doing inclusive work in that they were thinking about disability and trying to think about disability in a way that they felt like would be inclusive, but it wholly excluded the perspectives of disabled people. And I think we see a good deal of that. I mean, next in line, if I did a topology, would be kind of the token disability inclusive research. This is the one I dislike the most. I mean, this is where it's all too common. You get a group of non-disabled researchers, they decide to do a project, and then they decide along the way that it would land better if they included a disabled author. And so they find somebody and they typically put them on the author list towards the end of the author list down in the basement beside the boiler room. I think the only thing I can say about this is just quit. I mean, it's just not a good practice, and it's really disrespectful to disabled researchers. And so what that leads to for me are 3 categories that are better, that show that we are moving forward, and I think we can build on. One is consultation disability inclusive research. I mean, in this model, disabled people are consulted for their perspectives and opinions, and the researchers use those perspectives and opinions to inform the study. And I think this shows definitive improvement. I mean, especially regarding the earlier ones like exclusive research. But the role of the disabled people in the project is not one of leadership or co-production. So to me, this works. It's moving forward, but it's not where we want to be as far as our goal. To me, if we raise the bar, the 2 categories I like the most are the disability co-produced and the disability led research. I mean, to me, the co-produced works well when you've maybe are working on a project and there aren't disabled researchers yet with expertise in that area. And we find that sometimes that just disabled people have not made it to that point yet where they're in, we're in all fields, but that they are included in projects as co-producers, every aspect of the project. Conceptualization, design, methods, analysis, interpretation, publication. I mean, the perspective of disabled people is valued at every step. And to me, this is a reasonable goal, especially if the project lead or leads are not disabled. And then to me, the one I like the most, obviously, as the disabled scholar, is disability-led inclusive research. I mean, in this model, disabled researchers or collaborators lead or co-lead every aspect of the project. It's not possible, I think, in all instances, but when possible, to me, it's one of the best forms that we can use. I mean, I think we could quibble about language and categories, but my point is that it's time for us as researchers, and to me, this is how we move forward, to begin being honest about how inclusive our disability inclusive research actually is or is not. And so back to the original question, how do we move forward in including people with disabilities participants? I think if we're not willing to abandon the low bar term, we as researchers should be more honest about our endeavors and use some type of typology, such as I suggest, a self-report, what we did and how inclusive we were or were not.
This is Jennifer. Thank you so much, Scott. I really, really appreciate that. And I appreciate that so much also in context of Jean's kind of comments starting us off at the very beginning, just talking about those barriers to training researchers and keeping researchers who are disabled as well. And so, certainly see connections there with your comments as well. So thank you. Grace, this next question is for you. So what are the most common barriers, do you think, for disability inclusion? Time, funding, IRB training, others?
Yes, this is Grace. I think we've discussed this throughout the day, really, but there are many barriers to participation. And I think, especially in, for example, clinical trials, I think the systematic exclusion of people with disabilities is a huge barrier. Oftentimes, disability can be included in the exclusion criteria, and we know people with disability, 1 in 4 people live with disabilities in the world, and yet what does that say about the generalizability of the results if people with disabilities aren't included? I think also there's a lack of legitimate scientific justification of any exclusion that might occur. People just exclude people with disability without feeling that they have to justify it or explain why or the methodologies behind it. People with disabilities should be included in research, in all research, and yet that's not being done. Another common barrier, like we said, is time. Is there adequate time? Is time built into your study procedures? Did you have someone with disabilities look at your study procedures and understand some of the common issues and challenges that might arise that if you had just included them in the beginning, they could identify it and you could build in the necessary accommodations, accessibility needs, interpreters, plain language materials, easy read language materials, all of these things that are not easy, but they are identifiable, and there are ways to incorporate materials and methods that will make the inclusion of people with disabilities in research possible, and they should be included from the beginning. I think another common thing is funders. Like Jean mentioned, it's starting to become recommended and part of the funding decision for some funding bodies to make a point to researchers to have accommodations, to have reasonable accommodations. How you define reasonable accommodations is another issue, but just having that conversation started is, I think, necessary and a starting point. Of course, we need to go beyond that, but there are many, many more barriers, but I think those are some of the main barriers are accessible materials, adequate time, and inclusion of people with disabilities from the beginning.
This is Jennifer. Thank you so much for those thoughts, Grace. I think that they're fantastic. My own experience as a researcher is that a lot of times the way that we're taught to think about things is almost to maximize the measurement of things, make sure we're collecting the DEXA or whatever it is that we want to, and we don't really stop to ask and think about, by doing that, who are we excluding, and we're actually imposing this selection. And so I appreciate your comment on generalizability so much. Because I just find that we're almost trained in scientific rigor to prioritize the measurement over the selection and not really think about the barriers that we're creating when we do that. So I appreciate that comment. Thank you. We have one more question for our entire panel, and then we will open up the floor for questions. So Scott, if it's okay, I might start with you this time. And so the question is, how can institutions of higher education, like Johns Hopkins University, like other universities, promote disability inclusion in research or more, again, kind of disability-led and co-led work?
And I think an obvious answer is an event like today, where there actually is space to talk openly about this among researchers, is so helpful, because we don't get that much within the structures of universities. This topic is typically not on the agenda for when research is being discussed. I mean, I think the second thing, and I think I probably only say this because I've spent a couple of years as the co-chair of the Syracuse IRB for the past 2 years, is I think IRB has a large role in this as a gatekeeper of more progressive disability-led or co-produced research. I mean, I've been at universities where IRB really was a barrier to doing good, robust, disability-centered research. But now that I've been one at Syracuse, Katie McDonald, some of you know, was the chair here and really set the stage of trying to make sure that the IRB, the policies and procedures, are not just accessible to doing research on disability, but that we as an IRB committee are pushing researchers to say, tell us exactly what you're doing to ensure this research is inclusive. That's one piece of it. And the other thing, as someone who's low vision, is that IRB documents here are accessible, which has not always been the case, that as a disabled researcher, you can access and get to that. So I think these key institutions, be it a disability research center like the one at Hopkins or things like IRB, it's going to take, to me, getting disabled people or allies within leadership positions within these institutions to help maybe shift the dynamics to be more friendly.
Thank you so much. Grace, can I ask you to go next?
Yes. Oh. Tess, yes. This is Grace. Building off of that, I think from a student perspective, I think including this topic in the curriculum and just getting the conversation started. I think a lot of students are interested in learning about disability and how to conduct research that includes people with disabilities as co-researchers, as leads. But they might not necessarily know how to do that and the methodologies and the good practices in order to carry that out. So I think universities can be a good place to learn for students. Now, you need to make sure that you're teaching the curriculum in the correct way and you're promoting the right procedures. But I think it's a good opportunity to push forward and lead the change for the next generation.
This is Jennifer. Thank you, Grace. Jean, can I ask you to finish us off?
I'm going to chime on with that IRB piece too. That really, I think, struck a chord with all of us. Yeah, I worked at KU for 29 years, and there was a real evolution in our IRB and understanding disability. And I guarantee you, had someone said, oh, we're going to exclude people with disabilities from our study because they're a vulnerable population, 20 years ago, that wouldn't have been a problem at all. They said, yeah, we agree with you, no problem, go for it. And it really has been good to see that an awareness has built as more disability research has been conducted at the university to understand that disability is part of human diversity, and this is a population that needs to be included in all studies, just like everyone else. So, but at times, the IRB still can put up some roadblocks to good disability research because there is that concern about vulnerability of certain populations, and you do have to address that. But it's an interesting dilemma because disability researchers really want to include people with disabilities, and sometimes IRB can still make that a little bit problematic. So it's important to provide that education to our IRB members as well. Moving away from that, I would just say that universities in general need to have disability visibility in all of their materials, their websites, their written materials. They need to have accessibility of their website, their student housing, their information, their campus, and they need to have flexibility in their program. And the COVID pandemic was a terrible thing, but I think it really taught universities a lot about flexibility and how things can be done in alternate ways. remote learning and remote teaching are real things now, and they empower a lot of people with disabilities to be able to participate in ways that they hadn't in the past. I'm going to keep pushing for part-time work because I benefited from not having to work full-time throughout my career, but it came back to bite me in other ways sometimes, because there's an expectation that if you're in academia, you work full-time and usually like more like 60 or 80 hours a week. And some people with disabilities just can't do that. And universities really need to step back and think about why they have the requirements that they do and if those are necessary for people with disabilities. So I guess I would end with that, is that flexibility is really important, and not just the letter of the law and what a reasonable accommodation is, but really meeting the needs of valuable researchers with disabilities who want to do good research, but the university puts up those roadblocks.
This is Jennifer. Thank you so much, Jean. I appreciate that. And the flexibility, yes, I'm 100% with you, particularly for education and for many of us who are working there as well. And it does just strike me, I know this last question had to do with what can we do, at university levels, but you listening to the responses, it does just strike me how we tend to teach what we know, and again, tend to kind of work within the frameworks that we know, and that there are probably some, bigger structural changes that can be made to help with this. I think we've already discussed today thinking about changes at funding agencies. At the NIH grant, we're required to have comments on aging across the life course. We're required to have comments on diversity and race and ethnicity and in biological sex, but we're not required to have, with disability. I also think with journals now, there's so much we can put online with our methods, but we don't prioritize talking about inclusion and that sort of thing in journals as well. So as editors on those journals, maybe, that's something that we could move to do as well. Thank you, everyone, for comments so far. We do now have some time where we can open it up for questions, either on Zoom or in the room.
Thank you all. This is Bonnie. We're going to start with a question we have from the online crowd, but I want to just take a point of privilege and say that our own IRB system here at Johns Hopkins is highly inaccessible. So if anyone is listening that would like to change that, please keep fighting. All right, so we have a question. It's flagged for Jean, but I suppose anyone can chime in on it. Is it true or still true that federal grant research funding has been cut for students at NTID, National Technical Institute for the Deaf?
I don't know specifically about that particular institute, but research funding in general has been slashed in the last few years, so it wouldn't surprise me. And if that's considered part of DEI, then even more likely that it has been cut. Does anyone else know? I don't.
No responses. Yeah, it's for the person that asked that. Our federal expert, Anjali Forber-Pratt, said that she understands it was cut, but she's not sure if it was then reinstated. So
there was all sorts of legal pushback on it.
There's legal challenges, rightfully so. All right, thank you, Anjali. Any questions from the room?
So I am a person with disability, and I find this about the challenges of persons with disabilities participating in clinical trials and research surprising, because I've actually been part of 2 clinical trials which actually need people with disabilities first for cochlear implants back in the 80s when it was not FDA approved for marketing for children. So I was part of the clinical trial to get cochlear implant as a child. And then most recently, a second one, few years ago, actually here at Johns Hopkins, to take part of a study for a drug that has the potential to slow the progression of blindness, a condition that I have. So from what I have seen, a lot of clinical trials actually need people with disabilities because the interventions are for people with disabilities, but then there are other areas where people with disabilities can't participate in clinical trials. I would love to get clarification on what type of studies actually won't allow people with disabilities in the tons of others where the purpose is for people with disabilities.
Yes, this is Grace. And please feel free to chime in as well. But from my understanding, I'm very glad you had experience with that. But I think for some clinical trials, I think they might not, it's not a explicit exclusion. It's an exclusion in that there's not accessible material. There's not accessible location. There's not accessible transportation. I think, yes, there are certainly examples where people with disabilities are explicitly excluded. For example, they're listed in the exclusion criteria, but for for many different examples of implicit exclusion where it's just not feasible or accessible for people with disabilities. And in that way, a lot of clinical trials are not accessible.
This is Jennifer. Thank you, Grace. If it's okay for me to add to, I think a lot of clinical trials really do try to focus on maintaining their study participants during the entire course of the study. And they really want to try to maximize the internal validity of the study findings. And so we do tend to have a lot of exclusion criteria, just things related to, is this person likely to be compliant? Even some simple things like that. I work in the aging space. We have a lot of clinical trials that are done in studies of older adults, for example, where if you have major comorbidities, you might be excluded out of the fear that you will not be able to stay in the study for 3 years, that you would drop out, and then that hurts the internal validity. And so what we end up with is a very, very selected sample of people who meet all the inclusion criteria, who are then enrolled, who do not represent the broader population that we want to be applying to. And then I think, Grace, your point is so critical. On top of that, now we add all these things that people just aren't thinking of. And so I think it's problematic in both areas, but it really is heartbreaking to me, I think, as a researcher, that we tend to do things based on convenience or what we think the study should be about, rather than thinking long-term, how does this translate? How does this represent? What do I actually want to learn from this study? And I think if we take that viewpoint, we start thinking about the selection of our participants in a different way.
Can I jump in on that? I mean, Jennifer, I think it's a great, this is Scott, it's a great point. And I do think, and you had mentioned this earlier in your comments, that, when we're applying for grants, things like that, we're not required to give any statement about what we're doing regarding disabled people or inclusion. And I wonder if there would be effectiveness, especially on an IRB level, to purposefully be asking those applying for approval to explain, how they will be managing disabled participants. Because I do think there are some people that just don't think about it, and they just don't give it consideration, or if they give it consideration, they just really don't know what to do. And I do think that's where IRB would have a space to say, okay, but we're asking you to give us some detail on what could be done. Second piece of this, I've always wondered, could there be usefulness in a collaborative effort among disabled researchers to have some type of consultation service? Like if you've got a group of non-disabled researchers doing a project, it'd be so nice if they could, consult with a group of expert disability researchers and disabled researchers to say, okay, we're trying to do this. How do we do it well? Because not everybody's going to have that expertise. And we don't have, that I know of, we don't have any resources like that within the research field where, you could go to this group and get some immediate feedback on your project and ways to be more inclusive. And I think that's maybe one of the things that we could think about is how do we build that structure in place, either within universities or between universities, so that that resource is available to those who maybe just don't have this knowledge.
I'd like to chime in too, if I could. Getting back to the point about NIH, you have to detail how many people of certain ages you're going to recruit, how many people from different racial and ethnic groups, genders, etc. But they don't ask about disability. And I think this is a little off topic, but I think it's really important that disability needs to be included as a demographic in all of the work that we're doing, and not only in the research subjects, but in the people who are applying for the grants. We need to know if disabled researchers are getting funded equitably to people without disabilities. And I've noticed lately when submitting journal articles that journals will ask you about your race, ethnicity, and gender, but they will not ask you about your disability. So they're trying to see if they're being representative in the kinds of authors that they're publishing, but they're not getting at one of the major demographics that needs to be addressed, and whether that demographic is being reflected in the research that they're publishing. So it's kind of a side note, but I really think that disability needs to be seen as a demographic and data needs to be collected that way, the same as it is for those other demographics, or we're not going to know if we're making progress or not.
Thank you for a great discussion. I'm Sein Park, and I'm a disability health researcher and postdoc fellow at the NIH. And my question is, as Dr. Deal briefly mentioned, what practical strategy can researchers use to make secondary data analysis, especially longitudinal panel or national data sets, more inclusive of people with disabilities, in particularly a dissemination aspect?
Do you repeat I didn't hear all of the question.
Sure. My question is, what practical strategy can researchers use to make secondary data analysis more inclusion of people with disability, particularly dissemination aspect?
I'll jump in.
Well, I think,
go ahead,
Scott.
First thing I was going to say is you can't. I mean, if the data was collected in such a way that is not inclusive, you can't. I mean, there's no way you can change the data. And so I think what we've argued for, Jean and Bonnie and Anjali and myself, is more transparency. That researchers have a responsibility to evaluate the disability questions that were used to include participants and be honest about who really is being included and which disabled people are being excluded because of the way disability was measured. The other thing would be advocacy, to be contacting those who are collecting the data to see if you can help shift their perspective on what needs to be done to be more inclusive in their gathering of data.
I would just agree with that, and with the reservation that the way that disability is collected in different surveys is very different, and you just have to factor that into whatever analysis that you do until we get some more consistency in that variable or variables. It's hard to do.
Hi, can I ask a quick follow-up question to that? So as a person who works a lot in neurodevelopmental disorders, and in particular thinking about longitudinal cohorts, it seems to me much of the conversation has been around exon data or people diagnosed with disabilities or given conditions. So what if we turn the scenario on its head? Right, I'm part of a large national pregnancy cohort that is prospectively enrolling folks over time, right? And we're going to follow babies up for 10 years of their lives. Or in a large cohort where there's earlier data on kids and they're being followed prospectively into adolescence as part of a huge national consortium of over 60,000 kids, right? How do we work to sort of make sure that if data is missing due to disability occurring during the lifetime of this child in these cohorts, that it is somehow ensured to be informatively missing, perhaps, right? Or assessments are altered or supported to be administered to be more inclusive, to be able to capture that information where people would be able to contribute, which then in some ways might improve data and estimates on inclusion and disability and health over time. Because it seems to me some of the things we've been talking about are assuming that something has already been occurred or diagnosed or is happening later. But in these cases, in prospective cohorts, we'd be catching things sort of in time as they're happening. And so that perhaps provides opportunity to have that data be informative or changed administration. And as a specific example to share with all of you, we have in our cohort, there's an academic achievement test that's supposed to be administered. And the standard protocol says, coming from the NIH toolbox, that it should take 20 minutes. And so the kids with autism in our cohort need about 50 minutes and a lot of support on Zoom to take this 10-question math test, right? So this is a great example of sort of adjusting IRB protocols, and the reason we're able to do it is because our team is thinking about the fact that these are kids that we know have differences and need added supports to be able to be included. So that data is represented, right? That's not true everywhere. And so I would love to hear your thoughts on sort of, if we are thinking forward over time, right, as kids perhaps grow and develop, how we work to sort of approach this better in that way.
This is Jennifer. I might start so our panel can have the last word. I absolutely love that question, and I appreciate it so much. I will say, and I'm just thinking again for some of the neurodevelopmental things and neurodivergence related, right? So there are many of us in adulthood who have never been diagnosed. There's questions like this, right? And we have, within the research space, we have been able to develop algorithms to try to get at clinical diagnoses when a clinical diagnosis is not possible, right, in the time that we have. And there's certain ways that we can do that by collecting a broad amount of data. I think particularly like in the dementia research space where I do a lot of work, clinical diagnosis, but we're able to collect cognitive data, proxy data, family history, a lot of things that we're able to then kind of put together. I will say that I have put forward proposals to Johns Hopkins to develop an algorithm for developing autism or diagnosing autism, probable autism in people who are undiagnosed. And the comment that I got back is, this won't make a difference. So I think, we're facing challenges with funding, but I think there are methods that we can use and we can learn from other spaces, right? To kind of think, how do we get at this underlying thing without actually measuring that? So I do really appreciate that. And I think, as you say, the more data we collect, the better. There are, of course, different methods we can use, multiple imputation, probability weighting, things like that. But there's nothing better than good quality data to start with. So I really, really love and appreciate your question, I think, for that reason. I don't have a strong answer, just to say that I think there's more that we can be doing. And it starts, I think, with groups like you when you're actually really thinking about it and understanding your participants and their needs. So thank you for the work that you're doing there. I know that we are at time, but I do just want to offer it up. Any final comments from the panel?
My one last comment, I think one thing we haven't talked about is, they are, I think, legitimate gatekeepers, but editors of journals. I just think, wouldn't it be lovely if when a disability research project was submitted to a journal, that the editor not just required some type of statement on disability inclusion, but asked authors, did you include disabled people? Were they centered in the research? And if so, why not? I mean, to make this the new standard, that we're not just reporting what we did, but having to take responsibility and report why we did not do whatever it is we didn't do to be inclusive. I just think that could really shift things. If we could just see maybe even just one journal start this process, it could maybe kind of shift the landscape a little bit.
This is Jennifer again. Okay, well, I will just say thank you so much to all of our panelists for this really great discussion. Really, really appreciate all your insights. Thank you.
Thank you, everyone.
Thank you.